You go. Welcome to our series on substance use treatment. And this series will help the viewer to better understand the advantages of a medical model treatment program. We'll begin this journey with 5 digital workshops, and we'll add additional sessions with input from our viewers. My name is Catherine Hentrick, and I am on staff at Addiction Treatment Strategies, ATS, located in Edwardsville, Illinois, just outside of St. Louis. We have here today John Crum, the founder of ATS. Addiction Treatment Strategies is a 6-month intensive outpatient medical detoxification, stabilization, and treatment program. We are a therapeutically based, medically assisted program which provides an extremely effective intervention strategy for our patients. So let's get started. So let's start with a definition of a substance use disorder. In 1966, the AMA defined addiction as a chronic relapsing disease in which the structure and function of the brain has changed, and it's characterized by cravings, compulsions, and continued use in spite of negative consequences. While it may be helpful to know the functions of the various parts of the brain, that's not what we're going to talk about in this presentation. What is truly important to know, though, is that the brain has been mapped and continues to be mapped, so we have medical images to prove what we know about the brain and the effects of addiction on that brain. This information continues to become more clear to us with each passing day. Let's go ahead and return to that definition when it says the structure and function of the brain has changed. So it doesn't make sense to treat this disease, the one where the structure and the function of the brain is changed, by focusing on strategies that recognize that brain back to a healthy state. Addiction is not an accident. It doesn't occur by chance. Various communication pathways must interact in a synchronized and systematic process in order for the complex process of an addiction to occur. It is extremely complicated.
Probably one of the most complicated things for people to understand or accept is the conventional wisdom of what they believe that addiction is not a disease. Now, what we've done here, we put up on the screen Stedman's medical dictionary definition of what constitutes a disease so that you can clearly see that addiction processes fit the category of what the AMA describes as the disease. So a disease is an interruption, a sensation, or disorder of a body, system, or organ structure or function. Right there, that goes back to the AMA definition of a chronic relapsing disease in which the structure and function of the brain has changed. So that certainly meets the first component of a definition of the disease. The second component is a morbid entity ordinarily characterized by 2 or more of the following: a recognized etiology or agent. In addiction to an opiate or addiction to alcohol, that is for sure the agent. Identifiable group of signs or symptoms, that's the compulsion and craving component of an addiction, and a consistent anatomic alterations. Addiction meets all 3 of those criteria. An abnormal condition of a part, organ, or system of an organism resulting from various causes, such as infections, inflammation, environmental factors, or genetic defect, and characterized by an identifiable group of signs, symptoms, or both. So as you can see, Stedman's medical dictionary certainly includes all of that. Now, the DSM, the Diagnostic and Statistical Manual, defines substance use disorder as the essential feature of a substance use disorder is a cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continued to use the substance despite significant substance-related problems. What we have here is a neuron in terms of a component within the brain that you have about 86 billion of these in your brain that fire at the tune of 3 trillion times per second. That gives you some idea of how complicated the process is in terms of trying to determine how much of that you believe that you can control. So indeed, if an addiction was a component of willpower, you would be able to control the firing of these neurons. That quite simply is not true.
So when families and patients kind of hang their hat on a 30-day rehab facility, They're often disappointed with the outcomes, and they ask themselves, why isn't he better? Making changes to the structure and function of this brain takes time. It takes lots and lots of patience.
So what we're doing here, we have a hemisection of the brain. Back in when we were doing brain mapping in the 60s, we were trying to determine the internal functions of structures of the brain and neurological loops that were happening. Probably the main components we're interested in addiction is what's called the reward salience pathway or the dopamine pathway, which is what you can see in red there, the nucleus accumbens in the ventral tegmental area. And that's the current theory of what's creating addiction for a mental health issue. That's the firing rapidly in that pathway, or how quickly dopamine is released there. As you can see, it's also related to the memory and learning centers of the brain, which are in the limbic system. That's the amygdala and the hippocampus, where memory is stored. In reality, the two things that are happening is the ability of the mesolimbic system, which is those pathways in there, are now in control of the mesocortical system, which is responsible for inhibitory control, which is in blue up there, the prefrontal cortex and the anterior cingulate gyrus. So basically what's happened, the brain has usurped the power of the inhibitory control processes such that the limbic system or the addiction is driving behavior.
All right, so what we're going to do now is just look at a short YouTube video to kind of give you an idea of what this looks like. Let's get that done here. Share my screen with you.
What we have here is a rendition, a 3D rendition of internal functioning of the neuron. That's a neurotransmitter, the intracellular and the extracellular ions. That's basically how a neuron fires. From sodium, potassium, chlorine, inorganic ions goes intracellular, extracellular. That's how it moves from down the neuron down to transmitters. Which you can see, these are synaptic vesicles that are released into, they rupture and are released into synaptic cleft, which the ion channels are opened up, and those messengers there are transmitted from one transmitter to another one. This is an excellent 3D presentation of about what's going on in your brain with those 86 billion neurotransmitters.
Okay. So we've already determined that addiction is a medical issue. As you've seen, there's been lots of medical study. There's been lots of mapping done on the brain. So let's talk a little bit about two very popular approaches to substance use treatment. The first being a 12-step facilitation program. It's typically called the AA model. This 12-step facilitation philosophy, and I'm just going to give you just a few examples of those 12 steps that clients work through when they're working an AA program. So for example, one of them is come to believe that a power greater than ourselves could restore us to sanity. They made a decision to turn our will and our lives over to the care of God as we understand Him. Admitted to God, to ourselves, and to another human being the exact nature of our wrongs, and humbly asked Him to remove our shortcomings. So I've given you just a few examples here, and what I want you to do is look at that and say, what is the theme that we are seeing across an AA or a 12-step facilitation philosophy to treatment? One of them that we recognize is that AA is truly a moralistic approach to treatment rather than a medical. And it has the philosophy of once an addict, always an addict, which is just not the case. For example, when a client stands up in front of a room in an AA meeting and says, hello, my name is Kathy and I'm an addict, that speaks a lot to that person. It speaks to who they are as a person, rather than looking at the person first who has a medical condition. There's also a 30-day rehab philosophy and outcome. A 30-day rehab program began with the Hazelden Treatment Center in 1949, so it's been around for quite a while. The rehab facility plays an integral part in the treatment continuum, but it's just that. It's part of a continuum of services, a continuum of treatment options for patients. In 2022, SAMHSA's study indicated that 75% of our treatment programs utilized that AA model or some form of the 12-step facilitation as their primary role of clinical intervention. That means that 75% of the people enrolled in these programs are approaching treatment under a moralistic view to that. When really what we believe is that the primary role of rehab should be to provide a sanctuary to the patient and to the family in order to initiate treatment. Patients have to detox. Patients have to be at a place in their life where they can accept cognitive behavioral therapy, for example, or even begin to accept treatment at all. John, is there anything you'd like to add to that?
Yeah, I think it's complicated that oftentimes people see rehab as a place to start and in treatment in terms of 30-day philosophy. I think a rehab or residential care needs to be an integral component of treatment, and people should probably move in and out of rehab depending on the level of care that's necessary to meet their medical needs. It shouldn't be unusual, given the definition of addiction as a chronic relapsing disease, that people may have to go to rehab multiple times. Now, unfortunately, right now, when we have people going for 30 days, some people might need to go to rehab for 10 days or 7 days or 15 days, depending on the needs, as long as there's adequate support once they get out of rehab. And then they need to move back and forth in and out, depending on their level of success. So I think right now, one of the big barriers that we have to overcome is that people believe that if they go to rehab, they'll be cured within 30 days. And that just simply isn't the case. So oftentimes multiple rehab treatments don't end in success, and people give up on the concept of treatment just because they weren't successful in 30 days. I know that we have patients in our program. I think our standard bearer right now is an individual who's been to rehab 18 times in the time of the 4 years he's been with us. So it's a very complicated philosophy to overcome what people believe to be true from the statistics and the data that indicates we need to look at different ways for successful outcomes in patient care. We've changed some things here. If you remember, when we started the brief program, we used the AMA definition of an addiction, which is a chronic relapsing disease in which the structure and function of the brain has changed, characterized by cravings, compulsions, continued use in spite of the consequences. We've altered that just a little bit to make it easier to say that in reality, an addiction is a stress-induced impulse control disorder that leads to the use of substances or a behavior, really, to decrease the feelings of stress. In my opinion, it's simpler to define it that way because any imbalance in a person's homeostasis will lead to the use of a substance to make them feel more under control. Now, we don't often use drugs after an addiction is developed to what conventional wisdom says, oh, people who have an addiction are just doing it to get high. Oftentimes when you're dealing with addiction, people are using a substance to feel normal. And it's the lack of feeling normal that induces a state of stress, wherein they go back to using that substance to feel normal again. So it's really more of a stress-induced impulse control disorder. And then the second part, we repeated once again, is it's a repeat and consistent use of these behaviors. Thoughts, compulsion develops basically a condition, changes in the neurological structure and subsequent changes in the function of the brain. So we know that addiction is a learned neurological behavior of those 86 billion neurons that we're talking about. So it basically changes the firing sequence, and that's where an addiction is developed from our philosophy. Kathy, back to you.
Okay. You know, there's an extreme importance of having a shared definition amongst those people who are treating people with a substance use disorder. Conventional wisdom really dictates that addiction is not a disease, but a willing choice to continue using substances. And all one has to do to change is just quit using. And again, that is not the case at all. And the medical profession has proven that again and again. We can just ask Nancy Reagan that made the statement, just say no to drugs. And if it was that easy, we wouldn't have the issue that we have currently in this country and across the world. And only when we have a collective agreement as to what the definition is, can we have a scientific approach to eliminating the cause or causes of addiction. This is science, and the definition cannot vary, otherwise the outcomes or solutions vary. And just think of how confusing that is to a patient who moves between a 12-step facilitation in and out of rehab and to programs that are medical model. We really need to have a shared definition as providers so that it makes sense to the patient, not make sense to us as individual providers, but makes sense to our patients. The definition should most assuredly not vary from one governmental agency to the next, as this leads to confusion and, in reality, a lack of defining even success of those being treated. This leads to the stigma associated with those afflicted with addiction issues. So some persons don't really like the concept of addiction being called a disease, and that's one of the reasons that we're doing this series of presentations for you, is that we have a real desire to help the medical professionals working side by side with people in addiction to begin to understand the science behind addiction and begin to look at their treatment programs and see, are we dealing with a moralistic view at addiction, or are we truly looking at the science behind it? The confusion seems to arise around multiple points, including addiction appearing to be self-inflicted. How often have we all heard, well, if he never, used in the first place, there wouldn't be an issue. And that's not the case. And John can talk about that a little bit more here. Consequently, even some people believe that treatment should be all about willpower. And if that's the case, if you've ever seen or witnessed somebody in full-blown addiction, you will know that there are very few people who are there who want to be there. If it was all about willpower, when they're in their darkest moments, people wouldn't want to be in those kinds of situations.
So what we want to do is to remember what Stedman's medical dictionary definition is, and that's our premise in terms of what the AMA and Stedman said is it's an interruption or a sensation or disorder of a body, system, or organ structure or function. It's a morbid entity ordinarily characterized by two of the following: recognized etiology, which can be a drug, a substance, or even a behavior; an identifiable group of signs and symptoms. We have that comes from the DSM-5. Consistent anatomic changes. We know that from neurology. An abnormal condition of a part, organ, or system of an organism resulting from various causes, such as infections, inflammations, environmental factors, or genetic defect, and characterized by identifiable group of signs, symptoms, or both. To us, what that means is there really is a science to understanding how people got here. We're just not to the point yet where we have a consensus of opinion that there needs to be a scientific approach to how you treat someone with a medical condition of an addiction. So we have our philosophy here, and I think Kathy's going to go through this in terms of some things that we recognize when we put a scientific approach together that's going to differentiate from some other approaches. So we're going to go through those right now, I believe.
Okay, so the success of ATS really falls in these philosophies. The AMA was correct in 1966 in their evolutionary statement that addiction is a disease. We believe and we recognize that an addiction is a neurobiological disease process in which the structure and function of the brain has changed, which means that our treatment program should recognize that and should be designed to meet the needs and to help reorganize the structure and the function of that brain. We also recognize that an addiction is a chronic disease in which reoccurrence of use is likely. Unlike an AA program, when a client uses after 3 years of non-use, we don't say that patients go back to step one. There's been a lot of growth in those 300 days, and we recognize that, and we move off of that. We use a term that we don't use often, but general population understands a relapse. We use that. We use a client using after being healthy for a while to figure out why, what's going on, what was not in place, what fell apart along the way that caused this client to use again.
And a large part of what Kathy is talking about right here is the cognitive behavior therapy approach to, we have patients who obviously have been to treatment multiple times through the AA approach and some scientific approaches. And what they say, if I go 364 days without using, but I used on the 365th day, I failed for a year. I said, well, that brings a lot of guilt and remorse into what it is they feel about a neurological condition. And from our perspective, either you used or you didn't use. So if we go from, in reality, we're talking about a component of a harm reduction model. If we go from using every day to once a week, that's improvement. If you go 364 days without using and use one day, that's fantastic improvement, because we know neurologically the brain is improving, along with the psychological constructs that people actually are aware that they're getting better because they can track their time of being better. So that's one of the major changes that we see.
And the goal is treating and teaching the patient to manage their addiction, and no different than the disease of hypertension and diabetes. So understanding addiction as a neurological disease process in no way changes the individual from responsibility for a role in developing the disease. Again, in much the same concept as individuals that smoke are at a risk for developing lung cancer. And those that overeat and don't exercise, like many of us, are at a risk of obesity. And all that comes with that disease. At ATS, we recognize that the disease process occurs in a social setting. Therefore, treatment must occur in the environment in which the person lives and not in isolation at a rehab facility or in a hospital. We talked about this a little bit earlier, but rehab is a part of the continuum of services, and we recognize that. It has a place and it has its advantages. It just cannot be the only treatment, and it surely cannot be the ongoing treatment that the patient needs. Based on the unique needs of the patient, you have to design a continuum of services that work well. I've witnessed heartbroken families that when their patient is told that he or she should not go back home after rehab because there are just too many triggers, that just doesn't make sense. It makes no sense to remove a client, remove a patient from their home and from everything they know and they do. So again, we believe that we treat the patient in their home setting, in their home environment, so that they can learn to live within that home where they're meant to be. And the importance of individualized treatment strategies to address underlying mental health issues is also something we recognize, in addition to the manifestations of an addiction.
We have very few people here that we see that don't have some underlying mental health issue. It's not unusual for our people to come here who have, for sure, anxiety, depression, bipolar, ADHD. It's not unusual that we have, at the current time, we have 7 individual males who've been previously undiagnosed with autism. So they're high functioning autistic individuals who were basically using various drugs to feel normal, or in reality, to feel something. So once we identified that they were autistic, we altered and developed a unique treatment plan where we're developing cues and clues to teach them how to interact on a social level and not go to a drug as a component of how it is that they live.
At ATS, we also recognize the need for focus on behaviors and thoughts that promote health and stability rather than the disease of addictions. So what you would see in one of our group sessions, or even in our individual sessions, is lots of discussion on the behaviors that are being presented. We talk very little about addiction per se outside of the science, but talk about the behaviors and the incremental behavior changes that our patients are making. We also recognize the need for sequential and simultaneous integration of behaviors, emotions, and thoughts to influence brain repair and growth. Let's go back to the example of someone with a substance use disorder standing up at a meeting and saying, "Hi, my name is Kathy, and I'm an alcoholic, or I'm an addict," day after day. Think about the concept of engrams and forming memories that perpetuate that addiction. Known neurological changes occurring as a result of chronic use of substances, and the changes that need to be addressed in order to learn to manage the existing process is extremely important. So we spend, again, so much more time on looking at those behaviors and trying to mold behaviors that will help our clients to be successful. At ATS, we also recognize the role that patience plays in movement towards health, stability, and higher functioning. Our patients are not here for 30 days. The patients who achieve the most successful results participate in the ATS outpatient program for approximately 6 to 24 months, all based on their individual need.
So now that we've given you a little bit of background of what we believe and why we believe it and what's based on, we'll go a little bit over what's different about this particular model of approach to treating addiction. We've been using a medically assisted approach probably for almost 20 years now. It's an intensive outpatient treatment program that's formulated to address all the mental health issues that are involved in addiction. Basically, we believe we treat patients, or we treat individuals who present with an addiction to a substance or behavior, but you have to treat the entire person in order for people to get better. We also know that we've created a neurological approach to understanding the impact of the behavior on brain structure and function and the neurological change in the brain due to the use of the substances. So we track that very carefully in terms of how cells move and how they migrate. We're aware of that, and that's part of what we've developed in our treatment approach. So basically, whoops, gone.
Sorry about that.
ATS, there you go. Affects several centers in the brain, primarily the brain drug reward pathway, which is the motivational system in the brain that drives human behavior. So that's in the mesolimbic system, and the second part is the inability of the inhibitory control processes, which is in the prefrontal cortex, is unable to any longer exert control over the impulses of a new learned behavior, that of addiction to a substance or behavior. So the memory system then that continues to drive this behavior then becomes the neurological loop, or an engram, that's associated with addictive behavior in the first place. So the ATS approach focuses on rebuilding and integrating the behavioral system along with the memory system of emotions and learned behavior systems, such that the prefrontal cortex can resume control of the behavior integration. Now, what we know to be true is that you have about 1,400 new stem cells in the memory and learning center every day. Everybody gets those 1,400 stem cells in the hippocampus. They have about 28 days to travel down some of those neural pathways and become attached. Our intent is to get those neurons moving down, those stem cells moving down the mesocortical system, so that we can get them attached to the hippocampus, the memory learning center, so that we can reintegrate the prefrontal cortex so that you can exert some control of the addiction. And I think our next slide has a concept that comes from NIDA. And even though we don't particularly care for the concept of an addict, this is the reason that people with it shows on the left what a non-addicted brain means. That means the big blue ball that says control, that's the prefrontal cortex, which has the ability to determine the value of a substance or behavior, which is the salience, the red oblong ball on the left, which then determines the drive. Now, as the salience and the drive gets repeated in neurological loops, which is called an engram, then they go to memory, which then encoded, which then increases the probability that behavior will occur again. Now, people who drink, smoke, and chew don't necessarily develop an addiction. Now, if it becomes such that that memory pathway gets stronger and stronger, and the value of that substance, now as it increases from, if you will, basic chocolate to alcohol to methamphetamine to cocaine, the value of that gets larger in the body system, and the drive to get it increases, and the memory to get that drug increases. The value to control that by the prefrontal cortex is what becomes less effective, and that's the nature of the interrelationship between neurocognitive function and the mesolimbic system on the right side. That's how the brain becomes addicted. We can no longer control what it is we're doing, because basically the neurobiology of the brain is taken over and it drives human behavior. So our model involves both shaping behavior and teaching cognitively what's happening in the patient's addiction. We do that in both individual sessions, group sessions, and group education sessions, because we're trying to use some applied concepts and contextual learning techniques to bring about these changes. In reality, what's happening is the patients are accepting the fact that they have a brain condition, and they can regain control of some of how they think and behave, which then is indeed a cognitive behavior therapy approach to addiction. So what we teach our people here is various behavior modification techniques to help them change their behavior, which is the core of observed behavior in someone with an addiction. So CBT is the essence, where people oftentimes believe that they have to deny that they have an emotion, and that just simply isn't true. What we have to do is teach them that the emotion comes from the autonomic nervous system anyhow, and they can definitely, they can understand that they have the emotion, but if they can learn to be patient, they don't necessarily have to act on that emotion. And that's the essence of teaching neurological clues to say that the prefrontal cortex and then can re-engage your behavior, and they can practice behavior. So we have a lot of behavior management techniques that we use with our patients here, which includes obviously we have people who journal, we have people who exercise. We want them to keep track of something on a daily basis so that we can stretch their brain back into activities in the prefrontal cortex. So what we do is we teach patients behavior modification techniques to help change their behavior. And then we evaluate it on a regular basis. It's not unusual at all for our patients to journal or text staff in the evening to say, hey, I just learned how to do this, this, and this. And they're very pleased with what it is that they've learned to do. So why a neurological approach to addiction treatment? Because the science tells us that the brain has been changing and things have evolved considerably since the 30s and since the 60s. I was very fortunate in the 60s to be implanting hollow needles into rat brains when we were doing neurochemical research on internal mapping of the brain to see how and why which parts of the brains reacted in the way they did, which is the essence of the neurochemistry of brain physiology of what we're doing now. So there's undoubtedly a link in the neuroanatomical, neurochemical, and the effects on drug exposure in brain. People oftentimes think that alcohol is not damaging, and marijuana is not damaging. All of those things have an impact on brain structure and brain cells. This link proves that addiction is a medical issue that causes these brain changes and brain damage, and must be treated as a medical condition and not just something about willpower. So our goals here and our treatment program is, let's see, behavior would be anticipated. Let's see. The effect of our treatment program should be designed to address our neurological changes in the brain and its behavior implications, because the first part, what we see when our patients come in is their attention span is extremely limited. Their spatial memory is not functioning, and their anxiety, irritability, all those things are sky high when they come to the program. And it may take, in reality, almost 6 months for them to be in a position where they can engage in a simple 5-step daily program. Our 5-step program starts with make your bed, do a sit-up, do a push-up, journal, write something in a journal, have a daily plan, and exercise. So we know that it takes almost 6 months for people to be able to begin to do very simple tasks. So our goals are to support the patient as they develop these skills in a non-judgmental and non-critical approach to teaching them how to be stable and healthy. We changed the word stable and healthy. You can see there's not much of a stretch between being sober or stable and healthy, except for sober. Being sober involves the absence of drinking, and sober also then would be in the neurological link or an Ingram that's related to addiction. So we have to change the nomenclature in order for those Ingrams in the brain not to fire. So we talk about people becoming stable and healthy, which is a big stretch in how we go about altering a person's perception of what it is that they need to be doing. We also move towards some level of higher functioning on the individual. We track things on a daily basis so that we can keep track of how many days out of 7 did you make your bed. Some people can do it in the beginning, 1 out of 7, 2 out of 7. So we can move very slowly and seeing so that their self-esteem improves as they get better. We restore and rebuild some of the executive function, decision making, and their capacities that do that are definitely been impaired through addiction, because that's the whole nature of addiction, and impairs decision making in the prefrontal cortex. We have 4 major areas that we're looking at when people are doing something in our treatment groups and individual. We say, how are you functioning with regards to your health? How are you functioning with regard to legal implications? That means someone who has DUIs obviously has some issues. If you're on probation, you have issues. How is addiction or your use of a substance or behavior impacting on your job, your vocation? We have a number of people who in 6 years have 6 different jobs. And so they say they're very good at getting a job. I said, well, that's a distortion. That means you're also very good at losing a job as a result of your addiction. And indeed, the hardest part probably for our parents and for our spouses is the nature of the impact of addiction and use of substance on relationships. We have a relationship, we have a group here that we foster to inform them of what's happening to the person who has an addiction. So it's extremely important, almost on a weekly basis, to ask all of our patients, how are you doing with regards to your health? You need to see a physician at least annually. How are you doing with regards to your legal implications, your vocation, and relationship? So all of our treatment plans revolve around doing better in those areas. Obviously, with addiction, we're concerned with our health primarily, both mental and physical. So we have a 5-point treatment plan. All of our patients can be evaluated by our physician, or we will work with their physician to get medical intervention assistance. Invariably, most of our patients are on some type of anti-anxiety, antidepressant medication. They can also be on something to be detoxed from an opiate. They may be on Suboxone or Suboxone maintenance. When Suboxone first came out 12, 15 years ago, it was seen primarily as a detox agent. Obviously, we're getting a little bit better on our medical intervention to realize that it's a sustained medication. It should be used for an extended period of time for those people who need it. Our goal would be to get everyone off of all medications if they don't need it. That would include our opiate patients. We have people who've been on Suboxone for 5 or 6 years and have been successful in getting off. We have people who are doing very, very little Suboxone, but they're maintaining their health, legal, vocational, relationship issues, and they're evaluated on a monthly basis. We also have individual therapy for all of our patients. We're available 24/7 for our people in crisis. It's a requirement here to see your individual therapist at least once a week. And then we go over their treatment goals and how they're doing with regards to the treatment goals. We also get feedback from family members if they need to be involved in our individual therapy sessions with them to make sure that we don't triangulate and do something where everyone has to be on the same page in terms of when we're looking for treatment outcomes. We have group psychoeducation where we teach our basic skill set in terms of why the ATS philosophy. We have 71 different lectures that we use here with a lesson plan and with handouts. We want people to do homework which is the essence of cognitive behavior therapy. We want them to do something. We want them to come prepared for group therapy. We want them to design 3 questions about their treatment and what it is that they need to be looking at so that they can all contribute to the psychotherapy group processes. And then we use those as basically as group dynamics. What other common things do you have to bring up in group? And they're all responsible to be presenting something in our group psychotherapy groups. We also have a family orientation group that meets weekly. For me, those are probably the most difficult groups to do because we have parents and loved ones who obviously feel helpless. They don't know what that they need to be doing different, and oftentimes they feel as though somehow or another, if only they would have done something different, their loved one wouldn't be in this position. And we try to bring them up to speed in terms of how complicated the process is, and it's going to take some time. So we teach a lot of spouses and moms and dads how to be patient with their loved one, and we keep them up to speed with what we're doing in group dynamics so they can share some of our vocabulary so they understand what to expect. And it's not unusual to teach them how in reality to basically throw me under the bus when it comes to if your therapist said do this, why aren't you doing it? So it takes some of the dynamics of animosity when patients go home and live with their parents. Say, well, what would your therapist say about this? So we teach them how to deflect some of those issues so that they can treat them in a cognitive fashion and not an emotional fashion, because oftentimes some of these parents have been living with their 34, 35, 40-year-old child still living at home. So it's a very complicated process, and we try to include everyone in all 5 of these steps when they're here from up to almost, some of them, 2 or 3 years.
Yeah, and John, I think it's important for our viewers to know too that this is not, these therapies and these groups are not static. They're very fluid. So as patients come in, they may want to attend 5 individual therapy sessions a week because that's where they are and that's where they what they need at the time. They may attend so many education groups. They may attend so many therapy, and that ebbs and flows as the need arises. So it's not static. It's very fluid, and it's all based on their unique needs.
Yeah, and I think the fun part in terms of even in the groups that you're mentioning, Kathy, all our groups are open, meaning we may have some people in there who've been here for 2 years and some people who have been here 1 session. So the people who've been here 1 session, even though we have a patient manual, all that stuff, they may be somewhat overwhelmed, but it only takes a short period of time before they begin to learn the vocabulary, and they get an awful lot of support from the patients who've been here for an extended period of time, and they begin to use some of the same vocabulary and use some of the same skill sets. And what we find is that our patients begin to talk about their treatment with other patients here in the parking lot. How did you do this? How did you do that? So basically with the open groups, some of the people who've been here longer become surrogate therapists.
Definitely.
And I think that's a big positive of a lot of programs. Our medical intervention and assistance, what we do is for sure, we have a physician who can consult and he uses the clinical opiate withdrawal scale for people who come in. If they need to go to the hospital, we can get them to a hospital. If they need to be detoxed, if they're high-risk patients, we can get them detoxed in a hospital. And obviously the point of that is to decrease the withdrawal effects. The ones that are the most dangerous for us, obviously, is alcohol and benzos, because those are the ones that people can have seizures from. Also, obviously, fentanyl is a dangerous drug. We do urine drug screens on all of our patients here. We use cross-referencing from the parents, and if there's any doubt, we can get them to a hospital as quickly as possible. We also use various medications. The physician uses various medications beyond detox just to help them stabilize while they're here. And people, when as you know, when we use a substance to change brain structure and function, when we take that substance away, the ability to feel good in the mesolimbic system is no longer there. we're no longer producing in the nucleus accumbens in the ventral tegmental area, we're no longer producing dopamine. So they have a difficult time feeling good or feeling anything. So it may take an extended period of time for anti-anxiety agents and other medications to help stabilize people while we change some behaviors so that the brain can exactly reboot itself so that the dopamine system comes back online. And that takes anywhere from 18 to 24 months. That's a complicated process. So our one-on-one sessions address a lot of problems. Most people come and think that they're going to get addiction treatment, and they do. Indeed, we address the addiction treatment, but it takes a very short period of time to find out that most of our patients here also have anxiety, depression, other issues that they've been dealing with for years, which they don't understand that probably some of these issues is what caused their addiction in the first place. The depression may have led to addiction. The addiction could have also precipitated and caused the depression. But for the most part, what we find is what people are talking about now is what we call co-occurring disorders. They've been co-occurring since mental health began, probably. It's just that we're just now beginning to separate and see that there are multiple factors that lead into the complex process of why people develop an addiction. And all of those factors have to be addressed in an individual session. We try to work through these and give people opportunities to look at some of these issues that have been unresolved. It's extremely common that our patients have trauma, they've experienced trauma. A lot of our PTSD people, some of our people have been abused, but they've never seen the nature of the relationship between being abused and the use of a substance. So when you approach that on an individual level, they have the opportunity to understand better and really gain some self-esteem about some control back in their lives. So that's the purpose of our individual therapy as we do it. And some of our patients can see the therapist if they need to twice a week, so they can have as many individual sessions as they want. Our psychoeducation groups are also a lot of fun. We have sessions with a platform to study and comprehend various concepts that are unique to our philosophy. We have vocabulary words that we use that are different. As Kathy mentioned, we try to stay away from words that will fire an Ingram, which is the neurological loop. So we try to stay away from relapse. So when we tell people, did you relapse or did you use? So, you just used. So we're trying to get away from anything that will fire that Ingram again. So it's not atypical in some of our group psychoeducation processes. If we ask someone, even when we're teaching what it is that we do, we ask them, how many people in here are addicts? And if they raise their hand, they'll probably be chastised by other groups, by other group members by saying, no, we don't have an addict. You're a mother, you're a father, you're a brother. So we teach them how to be respectful of one another so that we get rid of some of the stigma that's associating with being called an addict. We don't use the term addict, and then we let other patients say, we're going to teach you what it means to have an addiction. You're all those things. In addition, you have an addiction. So we have lessons that teach both the neurobiological, the social, all that. We teach all that stuff here that's common to addiction. So when they begin to understand what it is that they're doing or why it is that they're doing, they can begin to use it so that there's some practical application. Once you have vocabulary, you have a background. So it's a basic text in how did you develop anxiety? How did you develop this? And then we teach you those things so that you can apply them in the group psychotherapy processes. So we offer all kinds of things in the latest research. The thing that we're looking at right now is how memory is encoded and what it means to a person who has an addiction, how memory is encoded and how it's retrieved and how it's processed. And what we're teaching people right now is that even though you think what your memory is, that the memory loop of an addiction doesn't just go in a closed loop, it reverberates. So when you try to identify a trigger, there's no such thing because the brain has spontaneous intrinsic firing. It will go off for no apparent reason. That goes a long way to taking away some of the guilt that people feel when they say, I have no idea why I did it. I said, I can show you why. It's the 86 billion neurons firing 3 trillion times per second. I said, you had no plan to use. There was no previous clue. Your brain reverted, it fired. So now we have to develop a strategy for how do we do something that we didn't know was going to occur. We can plan for it. So we teach patients strategies using the latest research and some of the implications that it has on their treatment. We focus on providing definitely an understanding of the physical nature of what addiction means, how it occurs, where it goes, and what we can do. And that's what we're doing in our education groups right now.
And as we're talking about the science behind addiction, when that finally clicks with the clients, you can almost see the guilt and remorse begin to just melt from them. They begin to understand, like John said, that this is not something that they chose to do. They did not plan to use yesterday. They begin to understand the science behind all of it, and again, that guilt, that remorse, just begins to melt away, which really truly helps in the healing process.
And I think what Kathy says is true. When you see people beginning to recognize that they're not a bad person because they use, I said, no, you have an addiction. You're not a bad person. So they felt, whether they've been made to feel or they feel automatically, they feel guilty and remorseful because they can't control their behavior. We'll go back to the slides where we showed you why you can't control your behavior, and that's a neurological process. Where we can teach people what that means and the implications for those things, then we can teach them also how to head it off at the pass, if you will. We can teach them through our group education sessions, and then when they come to group therapy, psychotherapy, that's an interpersonal process where we may have anywhere from 4 to 16 people in a group. It depends. We have groups that meet 4 times a week, so that we can cover people who work night shifts and people who work day shifts. We have groups that meet on Monday, Wednesday evenings, and then Tuesdays and Fridays as well. So all of our groups are about an hour. Some of them get carried away, sometimes go an hour and a half, and sometimes it's okay, 2 hours is enough for me. We take a break here. And so they process some of their complex fears, especially in regards to relationships. And some of our people obviously engage in high risk behaviors. It's not unusual for us to have patients who, as a result of their high risk behavior, become incarcerated. It's not unusual for us to lose a patient as a result of an overdose. So we have to, and we process some of that in group psychotherapy. When one of our patients is lost, our patients need to grieve that process, and they also become therapeutic aware of their risk taking behavior. So we also identify some of how are you getting better. So reduction of symptoms, people don't know on a day-to-day basis. So we try to track that. We want them to keep a daily plan and say, how are you doing with regards to this? So 6 months in, they're doing better than they were the first 6 days, but they don't track it because that's an incremental behavior change. And we teach them how to track those things and process it. So the people who've been around in the groups longer give a lot of feedback to the people who have been in a less amount of time, that some of the feelings that they're having in the beginning will take some time, but they will improve. And as they improve, the motivation to continue making some of those incremental mental changes and behavior changes also expands. So we get to do that 4 or 5 times a week. The sessions provide the opportunity really to safely confront some of the issues they're dealing with. We do talk about how do you get along with your parents, how do you get along with your spouse, what is it you've learned, what's a better way to be a little less confrontive when your parents accuse you of something. As all of you know, deceit is an extremely large factor in dealing with people who have a substance abuse disorder. And so how do I deal with the fact that my parents or my spouse thinks I'm lying all the time? That's an ongoing topic in terms of how to address that. They're designed to offer feedback from other patients who may have seen this behavior differently, and it allows them to reconsider other ways to make changes that are more functional. So it's a lot of give and take, a lot of feedback, and then the groups are obviously guided in terms of, I tell people that they're the instruments in the orchestra, and about the only thing that we're doing from the guiding standpoint is says that, you're a little out of sync here, you're a little out of timing. Here, try this and see if this works better for you. And then we get feedback. Did it work or did it not work? And oftentimes it's the patients who are giving the other patients some more functional strategies or things that they're more willing to listen to in our group psychotherapy processes.
And then what I feel is probably an extremely integral part of the ATS model is that family orientation and support. We offer weekly group sessions to encourage families to participate in the understanding and management of the patient's addiction. So just like our clients who come in, again, because they've been exposed to other models, whether it be the AA model or a moral model, so do our families. Our families come in with preconceived notions about what an addiction is and why it happened. And so during those family orientations, whether it be husbands, wives, siblings, parents, we really try to break down that mindset and really try to help families to understand the science behind the addiction. That goes a long way in helping to build empathy for their loved one's condition. It helps them to be able to recognize the small changes that are being made along the way, and helps them to be able to celebrate those along with the client. So again, it includes an orientation to the medical components of an addiction, and really differentiate between the old school thoughts of an AA approach and the more clinically effective neuroscientific and CBT approach of managing a behavioral condition. So, as patients change, there's always changes in family dynamics. It never ceases to amaze me as patients get better, families sometimes get more worried. Because they don't feel like they need to control as much, or they're losing control, and they're feeling very uncomfortable with giving up some of that. And so that's a big dynamic that we really try to work through with families. What are they doing to help support? How are they providing, a support that is encouraging their loved one to continue to grow and get healthy, and what are the kinds of things that they could be doing that maybe are discouraging their patients. So it's a really heartfelt time to work with these families. They are going through a lot as they work through this. They're going through a lot in their communities with their families, and a lot of secrecy as well. So it gives them the opportunity to be able to talk very honestly and open with our other families.
A lot of what it is that we've been talking about are in a book called Cellular Migration and Neuronal Connections. It's a neurophysiological text that explains how the brain grows and forms new connections. The brain is constantly growing. And so what we know is addiction is an extremely complicated neurological process of changes in the sequence of neurological firing. That's really an extremely important statement right there. So what we have is these changes that go as a result of neuronal firing change and involve the encoding and the consolidation of memories such that they form what's called an engram, or a coded neurological sequencing. A gentleman by the name of D.O. Hebb in 1944 came up with a concept of what's called an engram, which is a loop of encoded messages. And so it's been around since 44, and even a gentleman as early as 1904, a German individual named Wolfgang Siemann, came up hypothetically with what was called an engram back then. So people have been studying these encoded messages, and it's only as a result of new methods in the science of tracking the neurology of the brain that we can begin to understand how these messages are stored and how they're retrieved in stored memory, and which in reality, this is the basis of what an addiction becomes, is how these sequences are encoded and stored and then retrieved as a result of stimulation of brain tissue and cells actually changing. So the science of addiction indicates that there are obviously genetic, environmental, and personality traits that are involved in developing these brain changes. We described it in Stedman's medical definition of disease, as well as those traits in the DSM-5, and those things basically overlap to give you the basis of why we do what we do here. The second part is we understand that there's no one way to treat everyone with an addiction. What we would do, we would urge, as a result, we would urge all practitioners who are treating people with an addiction to explore which intervention strategies are you currently using, and then modify your protocol to coincide with the current science of what is known about the impact of substances on brain functioning. Brain functioning or brain dysfunctioning in reality is what's causing a person to continue to maintain their addiction. And please remember, there is no such person or thing as an addict, but rather we're treating individuals with a medical problem of an addiction. Addiction is a medical problem and not a moral problem. Thank you all.
So we encourage you look at your current practices, your current state of thought, and really take into account the kinds of things that John and I have talked about here as you're treating patients. Now, if you're interested in receiving CEU credit for this workshop, that is available to you. What you'll need to do is write a 2-page reflection paper on how your thinking was changed after watching this digital presentation. You know, for example, what attitudes have changed, what practices will change at your facility, and then cite evidence from that presentation throughout your reflection paper. As you get ready to email that, and I've got the address up above to who that needs to go to, please make sure that in the subject line of that email that you put CEU request for substance use treatment, the ATS methodology workshop. And that email needs to go to Carissa Vandenberg Clark. She is the assistant professor for family and community medicine at St. Louis University, and we've got her email there for you. So if you're interested in that CEU credit, please take the time to do that, to earn that credit. And we will be offering CEU credit for each one of our workshops. Thank you very much for attending.